EUS-guided Jejunojejunostomy to facilitate ERCP. A 61-year-old male presented with biliary obstruction. He had a history of biliary sepsis, treated with left hepatectomy, followed by roux-en-y revision with choledochojejunostomy years prior. He then developed an anastomotic stricture with chronic biliary obstruction and subsequently secondary biliary cirrhosis. Single balloon ERCP as well as EUS-guided hepatico-gastrostomy were unsuccessful in decompressing the biliary tree. Therefore, a decision was made to proceed with EUS-guided enteral-enteral stent placement to facilitate access to the biliary tree. The echo endoscope was advanced into the small bowel and the right intrahepatic duct was identified. A 22-gauge needle was used to puncture the duct. Contrast was injected and extended down the duct through the ampulla and into the small bowel. Filling defects consistent with previously seen intraductal stones were noted on cholangiogram. The echo endoscope was then repositioned and the opacified small bowel loop was identified. A 19-gauge needle was used to puncture the loop of bowel. Contrast injection confirmed location within the desired small bowel loop. A 0.035 hydrophilic guide wire was advanced through the needle and coiled within the loop of small bowel under fluoroscopic guidance. A needle knife was advanced over the wire and used to create the fistulous tract. The needle knife was then exchanged for a 6 mm by 6 cm dilating balloon, which was used to dilate the fistulous tract. A 15 mm lumen-opposing metal stent was advanced through the fistulous tract into the distal small bowel loop, and the distal flange was deployed. The deployed flange was then pulled to juxtapose the choledochojejunostomy small bowel loop to the more proximal small bowel loop. The proximal flange was then deployed. A 15 mm CRE balloon was advanced over the guide wire and used to dilate the lumen of the stent. Contrast was injected post-deployment to confirm correct placement. 14 days after the procedure, the patient was admitted to the hospital with right upper quadrant pain. Imaging showed development of an abscess extending from the bile duct through the subcutaneous tissue and eroding through the skin along the tract of a previously placed percutaneous biliary drain 4 years prior. Antibiotics were started and a decision was made to proceed with ERCP through the luminal stent for biliary decompression. The gastroscope was advanced into the jejunum to the site of the previously placed luminal stent. A 0.035-inch hydrophilic guide wire was advanced through the stent into the distal jejunal loop. A CRE balloon was advanced over the wire and the lumen of the stent was dilated. Cannulation of the bile duct was performed using a sphincterotome with a preloaded 0.035-inch hydrophilic guide wire. A cholangiogram was performed and showed a dilated common bile duct with dilated intrahepatic ducts and a tight anastomosis. The sphincterotome was exchanged for a 6 mm by 4 cm dilating balloon, which was used to dilate the anastomosis. A 7 French by 6 cm single pigtail plastic stent was deployed into the right intrahepatic duct under fluoroscopic visualization. Cannulation was again performed with a sphincterotome with a preloaded 0.035-inch hydrophilic guide wire. The sphincterotome was then exchanged for a swing-tip catheter to facilitate advancement of the guide wire into the left biliary system. A second 7 French by 6 cm single pigtail plastic stent was deployed into the left intrahepatic duct under fluoroscopic and endoscopic visualization. Stent positions were confirmed on fluoroscopy after deployment. The patient's bilirubin began to decrease slowly post-procedure. He was discharged home on a long course of antibiotics.